Any.
Are we live? Oh, okay.
Yeah.
Looks good live.
I realize we're live, but can you tell me when we're actually live?
I'll let you know.
They just happened. Great. We're live, everybody. Sorry, I just snapped at everyone. Welcome back. We're back after a short break. And we've got about 20 minutes. And I asked Representative Rebecca Daisy to, as I was sitting on the floor listening to all the bills coming to healthcare, I'm like, Rebecca. Hey, Daisy, why don't you tell us about some of the bills that you've introduced?
Thank you for giving the time. I do have several bills. And shout out if you want me to, I wasn't gonna talk about the one that we're talking about, which the prescription drug one.
Yeah, we don't need to do that one.
All right,
Let's start with their short form. So tell us about what
Yeah.
problem we're trying to solve. here.
522, H522. And have you all figured out how to find the bills on the legislative website? You can go to bills and then just use the search bar. That's the best way that I do it.
If you have the number, or I go to our healthcare page.
That's what I do too.
And it's bills in and out of committees. And it'll tell you all the bills that are in our committee.
And H522 should be in there. It's a short form bill. This is one that was up last biennium as well. It's intended to increase the oversight of the use of psychotropic medications for youth that are on Medicaid. So any psychotropic med that's used, like SSRIs, things that treat depression and anxiety are an example. Those are used off-label if they're used in children and youth. And they're used very heavily for kids with behavioral disorders or mental health challenges. And there is not a lot of reporting. In fact, I think it was the International Human Rights Commission actually did a report and found that Vermont is like severely lacking in oversight and accountability on monitoring the use of these drugs. So they approached and asked if we would consider increasing our monitoring and reporting from the Human Rights Commission.
Vermont.
No, national. Yeah.
Okay. And we're not, there's nothing in this bill that is banning the use. There's nothing that it's really more of an oversight.
Well, it's a
And-
short form. So
Yeah.
short form bills are, I do have like legislative language now, but it's, putting the conversation up there. And, I don't have a stance on this. I don't have any like specific things that I think we need to start monitoring. But let's, as a committee, I'm saying, let's please bring up this topic and talk about what the problem is and what we think we might do to improve it or solve it. I'm gonna go to 573. Okay, we're gonna get a little more technical. Involuntary commitment is when someone is, brought into mental health care, hospital level of care, by a physician, by being certified that they are a threat to themselves or others, and they're in need of treatment. So they're not voluntarily coming into hospital level of mental health care. There's a process. It's a very if you look at the statute for how involuntary commitment is done, it's very lengthy, detailed, I think confusing still. One thing that happens is at the start of it, there has to be a person who, say, witnesses an event if someone's in the community and having a mental health crisis. A law enforcement officer might, file a paper that says, I think this person is in need of mental health care, and then they have to be certified by a physician after that. Right now, there's not enough people, and VOS, the Hospital Association, noticed this. there are not enough people that can do that first step. It has to be done by a certain licensed person. And there are not enough people that are licensed to do that. So there's sort of this bottleneck. And these folks who are in mental health crisis are ending up in our emergency rooms where they are not getting care. Those people in the emergency rooms are not at all trained to support folks in a crisis. So what this bill would do is it would increase the type of folks to include physician assistants. So they could also help open up the start of this when people need to get into a higher level of care or get into hospitalized care. But it doesn't mean that it changes the bar at all for the requirements that someone needs to go through in order to certify that someone needs that level of care. It just simply opens up that bottleneck so that folks aren't languishing in an emergency room.
You have a question? Yes.
Here, question. So would they have to see a physician themselves? How would, okay, so
Yeah, there's
their choice to go see a physician and then seek additional help after.
no, so the first thing is someone has to fill out a request for a physician to come and certify that they need it. So that person, you have to have a physician, or right now it's a qualified mental health professional. And the hospitals are saying, can we please add physician assistants? Because that's who's most often available, especially in rural hospitals in Vermont. So we want to make sure that folks who are really actually the ones that are most often seeing these folks are able to do what they can to get these folks closer to care.
And correct me if I'm wrong, are we referring to involuntary or voluntary or both in this?
This is
This is
involuntary.
involuntary. So if somebody's seeing their own and decides to then seek additional, that would be voluntary.
Right.
So it wouldn't apply to this.
Is your question, Mallory, I do,
Oh,
for
go ahead.
clarification, how does, because it is involuntary, how does that nexus for that step happen? Like you've had the person report, and then you're supposed to see the medical, whatever category of medical professional is going to be able to certify. How does that happen if it's involuntary? Like they don't go knock on the doctor's door and say, here I am, check me out.
No, they don't. There's a form that has to be filled out by someone who witnesses
Mhm.
an event and sees that the person is potentially in need of mental health care or in danger potentially to themselves or others.
Mhm.
And then they have to get a warrant for a physician to come out and certify that, yes, this person is indeed in need of mental health care. And then they get in the custody of the commissioner. It's, like I said, a very lengthy process that is in statute and frankly, very confusing. I think we'll see other bills about this process possibly. I don't want to get into it.
I think if I'm not mistaken, I think judiciary. This is one area where our committee crossed the judiciary. And I think that they might have a bill. So we will probably do
Yeah.
maybe a sort of a flyover, drive-through. We try not to use drive-by in this committee. And we'll get into the whole process of like how it's set up currently for voluntary, involuntary. Yeah, and Katie, that brings Katie into the committee.
Is the person that, it's right now it's just a position that can do that, correct? And you're asking for the scope to be broader of who can. certify?
Yeah. Well, for the first step, it has to be, I think, a qualified mental health professional.
Okay.
And so I'm saying physician assistants
For
should be able
mental
to do
health.
it. Yeah.
Is there actually a certification for those that can do that, or is it?
Yeah.
There is.
PAs.
No, I mean,
For the mental health folks. Yes.
Okay,
Yes. And this is just the first step. They don't assess mental health or
Absolutely.
anything. This is just the first step of saying, yes, this person's in crisis and needs help.
And you expanded it to include nurse practitioners, master social workers, and just looking at the language. So it's beyond PAs, just really
Yeah.
expanded. So
Yeah.
thank
That's the proposal.
you. That's good.
Okay, great.
And then, there is.
Start with an H.
I need
Probably a 5.
I need reading glasses, you guys.
You got 576, 586.
586. 586 is reintroducing something, actually Leslie and I introduced together last
I was happy to
biennium.
see that. Thank you.
Yes, which proposes to limit the use of facility fees for certain hospital outpatient department services.
Can you explain that?
Yeah.
Well, this is a short form, so again, I just want to point out it's, not as detailed in its scope as the previous one, so it allows us to debate this because I think it's a very, we would have to do a lot of work having the hospitals come in and explain to us the variety of things that go into a facility fee. But this would say, if I go to the hospital and I'm getting a procedure that is, a minor procedure, I want us to have a conversation. Should we be paying a facility fee for that? Like, when is it appropriate? Should we standardize when it's appropriate and when it's not to pay a facility fee, which can be like $3,000, right? I think it's one way to look at addressing our premiums and penny affordability.
And I will just say that since I've been in the legislature, a bill like this has been in some form on every single wall. And I noticed that 585, Representative McFawn's bill had a piece in it. And I thought, where's our facility fee bill this year? And there wasn't one, so I asked the committee to do so short form on this. Because there is a piece.
So what authority are we gonna have over that? We can, facility fee. What are we trying to legislate?
Well, it's a short form to open the conversation. I have no idea, to be honest, what's our authority, but there is a lot of we can do in terms of the budget process, right? With the Green Mountain Care Board, we did some stuff with that. There's another bill, I don't know the number, which is related to this. And it would make hospital board meetings have to follow public open meeting laws.
Yep.
Yeah, because right now they don't. So nurses can't sit in on their hospital,
Right,
conversations that their leadership is having about their workplace. And I think that that's really unfair. So the bill would pull language from what we had for the ACO, kind of modeling after that as a starting point. But I was really shocked when I heard that hospital meetings are not open and following public meeting law, given the amount of federal and state funds that they receive.
And full disclosure, I intend, and I'm not quite sure when I'm gonna do this, because I'm still sort of waiting for a couple other things. But I really feel like we're going to do a deep dive on hospitals, hospital billings, different categories of hospitals and how they bill and what fees they receive and how they get paid. And so I feel like this facility fee, there's also a piece around some pay parity in one of these other things. And I'm hoping that we as a committee can really start looking into this and be thinking about ways that we can address some affordability issues within our healthcare system. Leslie.
So just to give a little context, about facility fees, in Act 167, it was recommended that we move out of hospitals, but into ambulatory care centers. Ambulatory care centers don't charge facilities fees, part of why they're much less expensive, whereas hospitals do. So it's looking at where those fees exist and how we can,
I was just wondering how we would be negotiating.
I don't think we're the negotiator, but we, create statute and we say to the Green Mountain Care Board to, think
Yeah.
about that. Yeah. So that's just an example of why facility fees can have impact.
Oh, no, I know that.
Okay, I wasn't sure.
I do understand that. I just
Okay.
wondering, do we legislate it? Do we go through the Green Mountain Care Board? Do we go through?
Yeah, we policy, they execute.
Yeah, okay.
Okay, I have three more really quickly because I think we have time.
Oh, okay.
There is another bill, I'm sorry, I don't have the number at this second, but that would move the Department of Substance Use into the Department of Mental Health. And on our list of reports that Jen and Katie were walking through, one of them was recommendations on improving AHS. And that is one of the recommendations that they came up with as well.
Sorry, can you repeat that? What was the recommendation?
That DSU be merged with DMH for efficiencies and because we know that substance use issues and mental health issues are often co-occurring.
Currently, substance use is in Department of Health, BDH. Mental health is within DMH, and because they are so often co-occurring, we have two different agencies that are departments. Brian,
I will say that we didn't go through what people's jobs are in the community yet, but I'm a clinical social worker and that we just did training at the designated agency on what is the new acronym? The BB something, the
BB, there's CCBHC.
yes, the CCBHC, to be a CCBHC. And we had to do all this training in recovery, like approaches to recovery. And it's pretty, like what SAMHSA is rolling out, you do not separate substance use and mental illness anymore at all. Like, I mean, that's in practice, we don't, but like literally the language is like, it is not recovery focused if you're not treating it co-occurring. So this is long overdue.
It's
in my
very
opinion.
long
Like, it's
overdue.
way overdue.
And it's, I believe in order for our designated agencies to receive the CCBHC designation, which allows them to receive higher reimbursements, or additional funding, they have to integrate the
Yes,
two.
we do.
And do we have to legislate that?
Not the CCBHCs, the state's already going forward with that without us. And they set their own requirements for it.
But it's in my opinion, inefficient.
Oh, I-
The government hasn't divided when the practice is
I know,
not divided.
I agree.
What do we do?
Yeah, well,
No.
we've divided it in the legislature too,
Yeah.
so we need to ask that we get the addictions portfolio here.
So that's where we have to do the work, is that high level policy statewide. To align with practice on the ground and the feds.
And not just practice, but the body and how it shows up, right?
You mean like science? The body
Yes,
that way? Yeah.
yes.
It didn't know about the legislative body.
Excellent.
Next one
only
is
got-
mental health and AI. So some people may have
I sent it to
read the
you.
newspaper and seen these really horrific cases of people who have completed suicide after chatting with a bot. And that has been researched, and one recommendation is that people take a look at limiting both the marketing of chatbots as mental health counselors or mental health therapy. It's just not. And so this bill really helps to put guardrails on that in Vermont, and so that those practices cannot happen here and masquerade as healthcare. It's not. And the Attorney General's office would actually have what's it called? There would be a fine. There would be a fine if people marketed those services, if they are not delivered by a certified licensed mental health therapist.
So consumer protection.
Consumer protection, thank you very much. And I know this is complementary to a bill that Brian has, which is much more comprehensive, that deals with healthcare and AI. And I feel very strongly about this AI and counseling bill. I think it's probably the most important one we have here. And it's co-sponsored by Angela Arsenault and Monique Priestley, who have led a lot of the AI work in the legislature here. So I really, really hope we can protect kids and adults. with this one this session. Lastly, kids and mental health. I have a bill that I am talking with the administration about, which would bring peer-to-peer, a pilot for peer-to-peer youth counseling to schools. This has been done in other states, great success. Kids should be talking to each other. We all know that not every school has the behavioral interventionists that they should right now. And we also know that kids and the peer approach is incredibly effective. So it does that. It also increases the mental health literacy for training for staff and teachers in schools around the state. And it would let the local school districts choose what materials they wanted to use. But there are some existing, like with NAMI Vermont and other places like that. We just want to formalize that we expect mental health awareness to be part of every teacher and anyone who works in the school setting.
Is there an age for the peer or?
Nope, that would be part of
Like in
what we talked
kindergarten,
about.
That would be part of what we talked about.
Okay.
So,
Could you give me a little example of the peer-to-peer? It's new to me. What would that look like? You would have a licensed professional or teacher who was trained in the room. And then, can you,
Yeah, so there's different models of how to do it, but basically it would be like a group setting of kids that, you know, if they're all, you know, struggling with depression or anxiety or stressed about tests or, you know, overworking or whatever issues kids have, body image issues, food disorders or eating disorders, they can come together in a group setting and find some, you know, peer support with each other and let each other know they're not alone.
So the person, would there be a person in the group that experienced that particular thing and has overcome it?
Yes. I mean, everyone would be going through recovery together. And for a lot of these issues that they would be talking about, it's a process. It's not like they had it and then it's done. Often these things are a lifelong challenge for folks, and that's why we need to keep talking about it with each other. But yes, there would be a supervising adult in the room with them all the time.
When you say any supervising adult, or is this somebody trained in mental illness or counseling of some sort, or just any?
Well, you know what? I want the experts to have the opportunity to come in and tell us what they think it should look like.
Yeah, we talk about mental illness in schools. I think it'd be important to have something like that.
Yeah, I think so too.
really quickly, because we do have to end.
Okay. When my first job in Vermont was a peer outreach program, it was 98 to 2003. And I'm not saying this is what they're gonna recommend now, but the way it did work is it was like 15 to 21-year-olds as the counselors, but we were all supervised by a licensed social worker, and we got the same training and supervision as, yeah, but we went out, it was different though, because we would go out on the streets and stuff. It wasn't a group, so I do think there'd be a value to hearing about the current models, but just to give you an example of how there's oversight.
Thank you, guys.
And then you have a DIVA technical bill,
I have a DIVA technical bill.
which thank you so much for putting in because I failed on
I
that.
thought Divas went to the Commerce Committee.
Okay.
I don't
That's a DFR. Yeah, that's a DFR.
No,